They proposed desegregation and as well as advocating for various other rights of the people with neurodevelopmental disorder. And from the 1960s was when the deinstitutionalization movement started. And I think it was more or less complete in the 1990s. And picture on the right is a mental institution for people with intellectual disability in Maryland. So what are the terminology historically of intellectual disability? Well, DSM-1 defines it as mental deficiency. DSM 2 to 4, we're all very familiar, terms intellectual disability, mental retardation, or MR. DSM-5 and ICD-11 is when the modern terminology came about, namely ID, IDD, or disorders of intellectual development. Intellectual disability occurs in around 1 to 3% of the children, and about half of them are idiopathic, namely you can't find it, you are not able to find a cause in these folks, and about 1/4 is caused by genetic reasons. The vast majority are mild. It is more common in males and more common in low to middle income countries. I've gone ahead and made a map of and found a map rather of the rates of people with ID that have known causes. And as you can see in more developed countries such as the United States and Europe, you have higher rates of folks with ID that have a cause. There are some notable exceptions. China, India, and Brazil actually also have decently high rates as indicated by the darker color. So how do you diagnose intellectual disability? Well, DSM-5 actually give us definitions. Criteria A, they have to have deficits in intellectual functioning. Criteria B, deficits in adaptive functioning. And basically for both of these criteria, you have to do clinical observation as well as standardized testing. And one of the important things to note that the severity of intellectual disability is based on adaptive functioning, not intellectual functioning. And they're separated into mild, moderate, severe to or profound, defined based on the severity of the adaptive functioning. They must have an onset during development. And some of the domains of adaptive functioning are listed here. And as you can see, they're conceptual, social, and practical. And the DSM-5 actually gives us examples in both the adult and child population. So what are the standardized tests for intellectual functioning? So for a test with a mean of 100 and standard deviation of 15, the cutoff for ID is 2 standard deviations below the mean, which is basically 70. And the Wechsler tests are the most widely used intellectual tests, and there are 3 individual tests, but they each offer a little different age range. If you had a patient that fits the criteria for 2 tests, you can actually choose to use either. I have given you an example here of a person that has normal intellectual functioning, and you can see some of the domains tested in the intellectual functioning. Again, I want to emphasize adaptive functioning determines severity. So how do you diagnose adaptive functioning deficits? Well, basically, the standard is the same. If you have a test of a mean of 100, you want 2 standard deviations or more below that to diagnose intellectual disability. Again, the 3 domains are conceptual, social, and practical, and that is defined by the DSM. The Vineland Adaptive Behavioral Scale is used from birth to 90, and it is the most widely used and has the most history. I think it also has the most research in regard to its validity. The four domains are communication, daily living skills, socialization, and motor skills. And you can sort of see that there's a minor, a little mismatch between the domains of the Vineland and the DSM. So basically, knowing that, people went ahead and invented the Diagnostic Adaptive Behavioral Scale, which is used in ages between 4 to 21. And here's an example, and you can see conceptual, social, and practical domains, which exactly matches the DSM, which helps people, I guess, have an easier time make the diagnosis. And it is also researched to have great sensitivity and specificity. What are some of the differentials for intellectual disability? Well, global developmental delay and unspecified ID are, they apply to different age groups. But what I want to emphasize is they are typically used when the folks that you're assessing cannot undergo assessment. And the common causes when they're too young is when they're just too young to participate. But when they're older than 5, common causes are sensory issues, locomotor problems, and behavioral problems. Your goal with these diagnoses is that you should reassess them when possible to give them a formal diagnosis. I want to spend some time talking about the etiology of intellectual disability. One big part of the etiology is genetic, and it is seen in between, I think, 1/2 to 1/4 of ID patients, depending on which study you look at. And for example, in this study, genetic causes is identified in about 1/4. And the most common is chromosomal, but you can also see single gene or mitochondrial causes. Down syndrome is the most common genetic cause. DeGeorge syndrome is the most common chromosomal microdeletion syndrome, and Fragile X syndrome is the most common inherited cause. So we're going to go over some of the individual syndromes that cause intellectual disability. Down syndrome, typically folks with Down syndrome have mild to moderate ID, but interestingly, their IQ actually drops in the first decade, and then it plateaus as they age. Dementia is a common diagnosis in Down syndrome. So by the age of 65, about 75% of them have dementia. As you can imagine, this probably exacerbates their cognitive challenges. The most common psychiatric diagnoses are ADHD, conduct disorder, and aggression. DeGeorge syndrome is caused by 22q11 microdeletion, and you will find palatal abnormalities, neurodevelopmental disorder, and cardiac abnormalities in this population. ID is typically mild to moderate, and similar to Down syndrome, they also have a declining IQ into their early 20s. One interesting paper I found is that 25% of these people actually go on to develop schizophrenia. And in the chart on the right, you can sort of see that people with DeGeorge syndrome without schizophrenia and people with DeGeorge syndrome with schizophrenia, the people with schizophrenia actually have a steeper decline of their IQ into their 20s, which I thought was really interesting. And here in this picture, you can see some of the characteristic facial features. Williams syndrome is another chromosomal microdeletion syndrome. Folks are characterized by facial dysmorphic features, cardiac, endocrine abnormalities. They have, vast majority have ID, and they usually are mild to moderate. They are generally very friendly. They have a big smile. They're disinhibited. So you can sort of imagine a lot of them are diagnosed with ADHD. Interestingly, 54% are diagnosed by specific phobia, of a specific phobia. Prader-Willi syndrome is one of those USMLE test question favorite disorders, but you actually see it quite a bit in the intellectual disability population. It is not only caused by microdeletion, it could also be caused by imprinting defect, maternal disomy. Patients with Prader-Willi syndrome eat a lot, and obesity and endocrine problems are found commonly. IQ is a little more impaired than some of the other disorders, 40 below average. Hyperphagia causes choking and gastric distension, and there are common causes of death, actually. 90% of the people with Prader-Willi syndrome have skin picking, and about 40% have psychosis. And as you can see in this study right here, this is deletion and maternal uniparental disomy. And the people who have maternal uniparental disomy actually have a higher rate of psychosis when compared to microdeletion, which I found interesting. This is a 19-year-old individual who have inadequate diet control and a BMI of 67. Angelman syndrome is the other side of Prader-Willi syndrome, and it also has 3 different causes. Folks with Angelman syndrome have ataxic gait, tremulous limbs, seizures. 100% actually have severe ID, and they tend to be nonverbal. Hallmark is frequent laughter and smiling, and hyperactivity is common. And as you can see in this picture on the right, this girl with a bright, big smile with Angelman syndrome. There's also some characteristic facial, hand features, as you can see here. Fragile X syndrome, it's caused by the CGG expansion on the FMR1 gene. It is an inherited cause of ID, and ADHD is found in 55% of the boys. And interestingly, autism is actually pretty common in this diagnosis. In the picture on the right, you can see, I like this picture. It shows you 4 different individuals from different racial groups, but they all have the long face, the big long ears. They also tend to have enlarged testicles in males, but which was one fact I did not know. Full mutation tend to have a bigger intellectual impairment compared with partial mutation. Rett syndrome is another one of the USMLE favorite questions. It is caused by a pathologic variant of the MECP2 gene. It is a sporadic mutation, affects almost all girls. And between the age of 1 to 4, there's this regression phase where the individuals affected lose their spoken language and hand skills and start to have some hand stereotypies. And as you can see in the picture on the right, this is a girl in that stage having some hand stereotypies. They're traditionally believed to have profound ID, but in recent years, using eye tracking technology, people have actually found 1/3 of them to have normal to mild ID. Anxiety is the most commonly treated psychiatric symptom in Rett syndrome. I think a good way to conceptualize environmental causes of ID as 3 categories: prenatal, in which alcohol is the most common cause, perinatally, prematurity is the most common cause, and postnatally, malnutrition and environmental deprivation are the most common causes. And as you can see in this study from this genetic center, you have about 10% of the people with the environmental causes of ID. Fetal alcohol spectrum disorders is actually several disorders, but the fetal alcohol syndrome is the most severe, and they are characterized by facial features, growth retardation, CNS involvement, and neurobehavioral issues. And I like this study right here because it compares the association between amount of alcohol consumption in the mother and the rate of intellectual disability. So basically, no risk is 1 and high risk is 4. And in the people with the highest risk, the rate of mental retardation or intellectual disability is also the highest. So the amount that the mother drinks does matter. And you can see their characteristic facial features in 3 individuals from different racial groups here. So what are some of the psychiatric comorbidities and how do you treat them? Well, I don't think we can adequately talk about intellectual disability without talking about autism spectrum disorder. It is defined by a persistent deficit in social communication and social interaction. And that could include social reciprocity, nonverbal behaviors, and deficits in maintaining relationships. Criteria B, restricted repetitive patterns of behavior, interests, or activities, onset and development, and they need to impair functioning. I want to shift your attention to criteria E, and it says not better explained by intellectual disability or global developmental delay. And one may ask, okay, so if there is criteria E, can you diagnose ASD and ID at the same time? Well, the DSM actually gives us an answer. The DSM says a diagnosis of ASD in an individual with ID is made when there is a discrepancy between the level of social communicative skills and other intellectual skills. Basically, in an individual who has impairment in all the domains, if the social communication domain is disproportionately impaired when compared to the other domains, you can diagnose ASD and ID together. 75% of the patients who have autism spectrum disorder also have intellectual disability, but the opposite is not quite true because only 28% of the patients with ID meet criteria for ASD. 6 to 7% of the people diagnosed with Down syndrome have autism, and up to 60% in Fragile X have autism. And one of the studies looked at the severity of intellectual disability and the rate of autism diagnosis, and it has actually found no association between severity and autism. ADHD is highly prevalent when compared to the non-intellectual disability population. In this study, it sort of shows us, it compares people with ADHD and intellectual disability and people who have ADHD who are non-ID. And it shows that people with ID have more severe intellectual disability, more severe ADHD and less improvement into adulthood. Methylphenidate has the most evidence, and there is a correlation between dosage and effect. And interestingly, atomoxetine actually has the next most available evidence. And I think there is only one study that looks at amphetamine. I think stereotypic movement disorder is a highly relevant diagnosis in this population because it basically is characterized by repetitive, seemingly driven, and purposeless motor behavior. And you also have to specify if there is or there is not self-injury when you make this diagnosis. You can see a variety of stereotypic movements and an individual with who's wearing a soft helmet because of head pain. I think self-injurious behavior is one of the comorbidities that psychiatrists encounter most because that's when they come to see us. And there is a cumulative incidence of around 5%, and it increases with age. Severity of adaptive deficits, autism, and absence of speech are 3 predictors of SIB. Social reinforcement actually has a role in this behavior, and I find this very interesting. Say a person with intellectual disability craves contact from their caregiver. Well, when there's low contact, SIB begins. The caregiver gives them more attention, and SIB ceases. If they're asked to do a non-preferred activity, SIB begins, they switch to, the caregiver gives in and switch them to preferred activity, SIB ceases. So as you can see, behavioral strategies probably has a big role in stopping SIB. And this is an interesting study that look at some symptom clusters and some problematic behavior in intellectual disability. And it has found that repetitive behavior and interests is positively associated with SIB, while impulsivity and overactivity is not. Aggression and destruction are two other problematic behavior. They also have a pretty decently high incidence per year, and it increases with age until 45. Like SIB, severity of deficit is positively associated, and absence of speech is associated with destruction. Impulsivity overactivity is positively associated with destruction and aggression, and repetitive behavior and interest is positively associated with destruction only. So how do you treat problematic behavior in folks with intellectual disability? Well, the FDA actually has some answers for us. Risperidone and aripiprazole are the two FDA-approved treatments. But you might ask, wait, it says irritability for autism spectrum disorder. Why is that relevant in intellectual disability? Well, if you recall from a previous slide, most of the people with autism have intellectual disability, up to 75%. So I think you can use that as a proxy here for ID. And the irritability here in the FDA's language, I think, is actually not meaning colloquial irritability. They actually used a scale called aberrant behavior scale, irritability, to look at aggression, as you can see here, destruction, and self-injury. So the irritability that the FDA means here is actually all of the problematic behavior. And risperidone and aripiprazole are both, shown to be effective in randomized controlled trials with good separation, as you can see here. This is risperidone. There's nice separation at week 2. Aripiprazole is significant at week 1. Evidence for other antipsychotics are present, but not as strong. Well, what if Abilify or aripiprazole or risperidone don't work? Thankfully, although there is no RCT for clozapine, one of the European countries, a Danish registry study actually sort of very well shows the power of clozapine in this population. They followed the patient for 2 years at a mean dose of 300 milligrams, and it actually shows that clozapine reduces inpatient admissions from 2.12 to 1.47, and hospital days from 99 to with a whopping drop from 99 to 32. So it seems like clozapine is a powerful tool in this population. And you may ask, what if the patients are psychotic? Does that still mean that, what if the study is based on people who are psychotic? Well, they didn't just look at people who are psychotic. They look at people who have or don't have psychosis. And if you look at the last item here, without psychiatric comorbidity, namely people who do not have bipolar schizophrenia or psychosis, it still shows quite remarkable reduction in inpatient days from 86 to 13. So the clozapine effect of to treat problematic behavior is actually independent of psychosis based on this study. Loxapine, interestingly, is tried in an open label study with a low dose of 5 to 15, which is way lower than the antipsychotic dose, but they were able to show some effect and no weight gain. Yet, since this is lower quality, it probably shouldn't be trusted as much. Depakote can be used, and in an RCT with individuals with autism spectrum disorder, it shows significant reductions in ABCI, as you can see on this graph. Clonidine is used, but often in folks with ADHD and hyperarousal at the same time. N-acetylcysteine is an interesting agent that we sometimes use in some of the disorders we treat. And in this study, which is open label, they treated folks with Prader-Willi syndrome with skin picking. And it actually shows resolution of symptoms in 71%. The pictures on the left are people before they were put on NAC, and the pictures on the right show their legs after they were treated with NAC. Naltrexone in our RCT with 33 adults showed no benefit versus placebo on the ABC or Aberrant Behavioral Checklist Irritability Scale. So how about psychosis? Well, it is more prevalent, both psychosis and schizophrenia is more prevalent in the people with intellectual disability according to this study. And there's high prevalence in certain syndromes, such as the George syndrome and Prader-Willi syndrome, as we mentioned. It is difficult to diagnose in this population, especially in severe ID, because a lot of them are nonverbal. When one tries to diagnose psychosis, one need to consider some of the common comorbidities, such as PTSD, which is commonly seen in this population, mood disorders, and epilepsy, actually, because a lot of folks with intellectual disability have comorbid epilepsy. I want to give you some examples of psychosis in people who are nonverbal. Acting romantically or sexually with animals, persons, or objects that are normally not part of their sexual repertoire. This could be command auditory hallucination or erotomanic delusions. Wearing multiple layers of clothing. It could be a sign that they're worrying about their body disintegrating or limbs falling off. The caveat of that is it could be a sensory thing for autism. Covering eyes or ears, it could be an effort to stop visual or auditory hallucinations. It could also be a sensory thing. However, unusual wrapping around ankles, wrists, or ears, it could be a sign that they are trying to stop invasion from sinister forces. Almost never psychosis in this population is self-talking. Neurotypical children self-talk tend to cease with development. However, the people with ID, their self-talking can persist well into adulthood, and shouts and screeches are almost always vocal tics, not psychosis. How about trauma-related disorder? Well, about 77 to 34% of adults experience sexual abuse, and actually people with milder ID tend to have higher rate of sexual abuse, presumably due to more participation in the society. Patients with sexual abuse with intellectual disability are more likely to score higher on the irritability scale, more likely to display sexualized behavior. And they are actually also more likely to have PTSD symptoms that is more intense than those who have PTSD caused by other forms of trauma. Eating disorders also quite commonly seen in this population, and obesity, as we talked about, is found in 100% of the folks with Prader-Willi syndrome and 25 to 43% in the folks with Down syndrome. About 35 to 72% of the folks with severe spectrum intellectual disability are underweight. Pica is eating things of no nutritional value, and it is commonly found. And one of the strategies is called overcorrection. I want to give you an example. Say a person with intellectual disability has severe pica and eats feces to the point of intestinal parasites. So what do? So in overcorrection, you verbally instruct them to go to the toilet and spit out the feces. You ask them to brush their teeth and use mouthwash. You ask them to wash hands and scrub fingernails for 10 minutes. You ask them to clean their anal area with cloth soaked in warm soapy water, then wash hands briefly again. And finally, the patient is guided to the area where they were discovered handling and eating feces and instructed to mop area with disinfectant. And this procedure takes about 30 minutes. In 2 weeks' time, the target behavior was completely eliminated in 100% of the patients. And the result was maintained for 7 weeks. Rumination disorder is chewing and swallowing regurgitated content. There are some behavioral strategies to target that as well. Food fattiness or refusal, or in DSM terms, avoidant restrictive intake disorder is found in about 30%. Picture on the right is in a agency that serves folks with intellectual disability. A registered dietitian's working with a client of choosing healthy meals. So catatonia is an increasingly recognized diagnosis in this population. However, it is challenging to diagnose catatonia in the neurodevelopmental population because there are a lot of overlaps, such as stereotypies, mannerisms, mutism, echolalia, and negativism. Is that caused by their neurodevelopmental disorder or catatonia? Well, in some studies, authors have proposed that you should recognize new onset symptoms and consider it worsening of symptoms as a sign of catatonia in this population, as well as a later onset, such as late adolescence, so that you have you can pick up these signs. Some argue that self-injury in autism spectrum disorder could be a stereotypy and therefore a sign of catatonia. There is significant convergence of biological mechanism in neurodevelopmental disorder and catatonia. The diagnosis and treatment is more or less the same. You use standardized rating scales, you rule out the medical causes, you use benzodiazepine along with other treatments, and finally ECT. Genetic testing might have a role in catatonia in this population, because I think there are some studies that look at specific genetic syndromes in which catatonia can be treated with agents that we don't typically think about treating catatonia, such as lithium. Neuromodulation have a role in this population as well. In an analysis from a large academic center, the most common indications of ECT in ID patients is catatonia, psychosis, and self-injury in that order. Almost all treatments are bitemporal, and as you can see, the outcomes here are quite excellent. TMS has a role in this population as well. Specifically in the study, they used inhibitory stimulation on the left and right dorsolateral prefrontal cortex, and it showed significant improvement in social relating scales. I think their proposed mechanism is that lack of cortical inhibition amplifies sensory stimulus, thus impairing functioning in ASD. And if you use a low frequency, namely inhibitory stimulation, you inhibit the inhibition and thus improving social communication. There's another open label trial that looks at using high frequency or excitatory stimulation for in the population with intellectual disability. And in this study, they looked at the inferior parietal lobule, the IPL, which is postulated to be involved in the mirror neuron system. Basically, they're saying that if you give high frequency or excitatory stimulation, it enables the individuals with autism spectrum disorder to interpret actions of others and develop social recognition. And it is also a positive study. I think applied behavioral analysis has a very big role in treating this population. And the core concept of ABA is consequence of what we do, affect what we learn, and what we do in the future. Positive reinforcement is one of the main strategies. And I want to talk you through these two scenarios. The teacher tells the student, "It's time to clean up your toys." The student yells, "No!" The teacher removes the toys and says, "Okay, toys are all done. No toys for you anymore." So that's an example of negative reinforcement. However, ABA recommends folks caring for people with ID to use positive reinforcement. So same scenario, time to clean up. The student is reminded to ask, "Can I have 5 more minutes?" The teacher says, "Of course, you can have 5 more minutes." And shortly afterwards, the student goes ahead and cleans up the toy and they get a reward. So that's an example of positive reinforcement. We are physicians and we cannot ignore the medical comorbidities in this population. In this Scottish registry study of over 1 million people, they found the people with ID to be overall younger, and they also have higher proportion of folks with one or more physical conditions when compared to people without intellectual disability. And I really like this table because it shows you individual conditions and the odds ratio between the folks with ID and the folks without. And epilepsy and constipation are the two conditions in which disproportionately affect folks with ID. I think it's important to realize those as a psychiatrist because we sometimes prescribe anti-epileptic medications, and some of our medications could contribute to constipation. And now I'm at my final part, which is the part that I'm actually most exciting about, because it talks about the social and practical aspects of care, which I think is arguably the part that is not emphasized enough in the medical education. But here we go. One of the questions I had when I was intern or second year in the EPS was how does a person with intellectual disability end up at their living arrangement? Who chooses and what kind of patients get to choose themselves? Well, I actually found a study that seeks to answer that question. This is a study in 2011 that involves 6,700 people with ID, asked two questions. Who chose the place where you live and who chose the people that you live with? An interesting feature of this study is that if a person can't report because of their physical or behavioral limitations, a proxy is used to complete these questions. You can see that in the results, there are three possible choices. Somebody else chose, person had some input, or person chose without help. So in the people who self-report, they are more likely to at least have some input into where they live and who they live with. However, people who use proxy are more likely to be completely dependent on other people choosing for them. But overall, if you look at both kinds of responses, about 44% of the people have some input into choosing where to live, and 40% of the people have some input into choosing with whom they live. Well, this study also actually looks at the severity of intellectual disability and what kind of settings they live at, which I think is very interesting. And it has found that those who have mild, moderate level of intellectual disability are more likely to live in their own home or agency-provided environment, and those who have severe to profound ID are more likely to live in an institution, such as intermediate care facility or ICF. So decision-making is an important part of caring for folks with ID. The vast majority of the times, full guardians are appointed and all of the person's rights are taken away. However, there's this relatively new concept called supported decision-making, and there's growing calls for SDM to replace guardianship, and it is actually endorsed by the United Nations. Basically, an example of SDM is what is called a representative agreement. A person with intellectual disability authorizes a third party to make decisions. They consult the rep, yet they retain the legal capacity, and the agreement can be terminated by them at any time. The Commonwealth of Kentucky actually, on their website, says that one should include SDM as a tool when considering guardianship and only promote guardianship as a last resort. And here I've included a spectrum of different levels of, I guess, decision-making structures. And you can see the most restrictive is guardianship, least restrictive is independence, and SDM falls somewhere in the middle here. So we're all humans, and people with ID might one day want relationship or want to have sex with the person they're interested in as well. So what happens when they want to do that? Well, there are also studies for that. And survey of caregivers actually show that paid caregivers tend to be more liberal on this matter than family, and folks with more extensive training in area of sexuality are more liberal. Survey of people with ID, lack of privacy for intimacy in residential settings, and a lot of them have to go to isolated public or semi-private places. There are some proposed learning objectives to better educate people with intellectual disability about sex. And the advocates for sexual experiences tend to say one has sexual consent capacity if rationality, knowledge, and voluntariness have been met. And they also argue that third-party assessment should be warranted when guardian and the ward, namely in this case, the person with intellectual disability, disagree. So what about income? I think this is a good opportunity to familiarize ourselves with the difference between SSI and SSDI. Basically, the most important difference is SSDI require one to work either themselves or their family. SSDI pays more, there is work requirement, and SSDI actually doesn't really care how much asset you have, but SSI limits your property to around $2,000. And there's a difference in what kind of medical insurance you get when you get approved for these Social Security benefits. And the criteria for SSI or SSDI in ID is unable to complete test independently, IQ less than 60, or between 60 and 70, and have some additional deficit. Some people with intellectual disability can indeed qualify for SSDI because they qualify it based on their spouse's or parents' work history. So in this study right here by the Social Security Administration, it imaginably shows a higher rate of SSI only in the people with ID when compared to people with other forms of disabilities, as you can imagine, because far fewer of them have work history. What about the waiver services? Residents would hear about these terms sometimes, but I didn't quite understand what they were. But basically, there are two waivers that are relevant in this population in the Commonwealth of Kentucky. They're called SCL waivers and Michelle P waivers. Basically, they're designed to deinstitutionalize and ensure that people with ID can live in the community. The SCL waiver was created earlier in 1999, and Michelle P waiver was created later when an individual named Michelle P sued the state because of the long wait list, and it was created in 2008. There is a difference between the quantity of service one can receive, and I think powerfully, SCL waiver actually provides residential services such as group home and family home providers. So there's a difference in their services. As you can see, I've went ahead and given you some examples of the services provided by the Michelle P waiver and SCL waiver. You can see a lot of it is similar, but there are some minor differences. So what about employment? Do the folks with intellectual disability want to work or have work history? Well, this is the same study from the Social Security Administration, and it compares the beneficiary with ID and the beneficiaries with other forms of disabilities. Basically, it shows that people with ID have lower rates of ever working, yet they show more desire and more, I guess, passion to get trained to work, such as higher rates for employment services use, goals, as well as work-related activities, such as looking for work. I think this is the part that I'm most excited about in this presentation, because supported employment is just such an elegantly designed social, I guess, construct that tries to help folks with intellectual disability gain employment. So if you bear with me and follow me here, there are four parts in this diagram. There's the state, agency, person with ID, and employer. Basically, the state will pay an agency for their help in supported employment. The agency will provide support to the person with ID, and the person with ID will give labor to the employer. The employer pays them a wage, and notably, it can actually be sub-minimum, and that is based on Department of Labor, Fair Labor Standards Act, and the wage can actually be determined by their productivity. So it doesn't actually just end there. When the person with ID start working, they actually draw less Social Security benefits. Their savings on programming because they are working instead of being in their programs. So the state save money that way also. And they also pay income taxes to the state. And the benefit for the employer doesn't just end there also because they get some tax credits for helping people with ID stay employed. So if you're not convinced already, I've actually looked at a study in 1987 from Virginia Commonwealth University. Basically, it's an income statement of employing a person with ID, and from the consumer perspective, namely the individual with ID, and the taxpayer perspective. So for both parties, if you subtract the costs from the financial benefits, you actually end up net positive for both the person with ID and the government or taxpayer. So essentially, it's saying it's creating more value for the society. And importantly, the person with ID becomes more self-sufficient and gain more meaning in their life. So economists actually take care of people with ID too. And KRS Chapter 202B is something that residents I find in their training are somewhat familiar with, but not quite, at least myself. Basically, it has all the same four criteria as involuntary psychiatric hospitalization, except the difference is that the people, when involuntarily admitted, is admitted to an ICF or intermediate care facility. It also requires 2 evaluators. But interestingly, placement is actually based on availability and not catchment area. And I will show you the implications in the next slide. But Kentucky law actually says if acute danger and concurrent mental illness are present, a KRS 202A should be followed because the process of granting 202B can take several days. So I think that is why a lot of people with intellectual disability end up in our emergency room on 202A, is because the Kentucky law actually says so. But in order to be placed in an ICF, people must have moderate or severe ID because the state argues that mild ID, they're too skilled to benefit, and profound ID, they're too impaired to benefit. And notably and importantly, community treatment options or waiver program services should be exhausted. This is actually a big, I guess, roadblock to folks being granted 202B in a lot of the patients we see at the university. So where are the intermediate care facilities? So half of them are in Louisville, actually. The picture on the left is Bingham Gardens. It is on the west end of Louisville in the red rectangle. And I want to give a shout out to the building on the right. That's the Lee Specialty Clinic, and I spent a month rotating there. As you can see, these are houses and they're not locked. So the patients actually walk out of their houses and wander around the area, which I found very interesting. And this is the other ICF, the Hazelwood Center, which is also in Louisville. The remaining 2 facilities are farther away, and interestingly named. They're called Oakwood and Outwood, and they're on the eastern end and the western end of Kentucky, respectively. But one of the problems is if admission is not based on catchment area, but based on availability, how far can they be placed? Well, I have given a hypothetical scenario. If a person is from Eastern Kentucky and they got placed at the Outwood ICF, their family would have to drive 5.5 hours to see them. Just something to think about. So we're almost at the end, but let's come back to the scenario. What would you do in this scenario, and what should you do? Well, if you look at the scenario, the family has exhausted the outpatient options. Basically, they call the therapist, call the crisis line. They've tried the 202B, yet the community resources are not exhausted. The community resources here are different from the crisis line, because the community resources here mean the services that are listed on the waiver programs. So what did they do? They actually went ahead and got granted emergency waiver so that the 202B can be upheld. But they couldn't find any agencies to provide those services that we listed, such as those two PDFs that we displayed in an earlier slide. So now there is an acute danger. He was hitting his grandmother and biting himself, and mother scared he would hit her. I actually think it's appropriate for her to take out a 202A because it feels like the law says so. My answer would be admit the patient to my inpatient psychiatry unit for acute stabilization while the family and social worker find an agency to serve him in the community post-discharge. And ideally, we can avoid further hospitalizations or intermediate care facility placement and can keep them in the community afterwards. And last but certainly not least, I want to read you a letter from a patient that was treated here, and it is not the patient's writing, it is transcribed. Attention, mom and doctor, I feel nobody understands what I'm going through. Not being able to see my siblings is too hard. My life went to hell. You said the day you visited that you cannot take care of me. You said you would never see or talk to me again. If you have other children at home, how come you cannot take care of both of us? Mom, I love you. I miss you so much. Thanks for doing my hair. I'm not able to control what I do, but I want to. And with that, that is all of my presentation today. And thank you for your attention. I will open it up to questions. Let's see, we have several hands raised. See, Dr. Swanson is here.
Yes. Can you hear me okay?
I hear you good.
Okay. First of all, Dr. Wang, I want to thank you for an excellent and comprehensive, you covered a lot of topics quite well and as succinctly as I've ever seen. And your presentation was just as good as your participation at the clinic. If you don't mind, I would just like to emphasize and highlight a couple of things you touched on, and one is the fact that common psychiatric problems, major depression, bipolar disorder, schizophrenia, anxiety, ADHD, are just as prevalent and sometimes more prevalent in this population than in our population, IDD population, as the general population. The problem is people lack the experience and training to pick up on a lot of the nuances and challenges. And you mentioned, psychosis in a nonverbal person. One of the big challenges we see is the concept of diagnostic overshadowing. And that is that persons who do not have experience with this population tend to incorrectly attribute symptoms to the developmental diagnosis. And when I started at Lee Clinic 8 years ago, I believe it was my second month there, I saw a dramatic example of this. And this was a young lady who has schizophrenia, who was having auditory command hallucinations, telling her to stick pins in her own vagina. And she was clearly psychotic, clearly decompensated. We sent her to a local emergency room, and the physician said that this was part of her intellectual disability and just a behavior, and denied admission. So I want to thank you for teaching us and training us and providing more exposure. And finally, maybe a shameless plug for any students or residents who would like to rotate through the clinic. We'd love to have you on board. You will see these patients with IDD as you get out and practice, but we'd love to have you on board for a day, a week, a month, however long you want to be there. Thank you much, Dr. Wang.
Thank you, Dr. Swanson.
Hey, well, I have a question, and thank you. That was a wonderful presentation. I know you've expressed a lot of interest recently in neuromodulation. Do you see any new neuromodulatory techniques being helpful for this population?
Yeah, that is a great question. I think that two TMS studies that I read are quite good. I think they use different techniques. I can't say I'm familiar with other sorts of modulation techniques, but I know you and Dr. Kalau are going to work on, ECT, and it seems like the ECT study, vast majority of them are bitemporal. But it'd be exciting to be able to see maybe a unilateral study in the specific population, such as self-harm. But what did you think, Nick?
I would agree with all of that. One of the things I think is interesting is trying to treat stereotypy specifically with, as you mentioned, transcranial magnetic stimulation, but there's also something called transcranial direct current stimulation that has shown some promise. So I think that those are some things that are worth investigating. But ECT probably holds promise, and unilateral may be beneficial because you do need to optimize the brain tissue that's left. You don't want to end up damaging it if you can prevent it. But there is probably a lot more out there. So we'll just have to see with time.
I see Dr. Oliva, Dr. Rabbani also.
Yes. Yes, I have a question, but this was a very great talk. Really, I learned a lot. My question is about the case that you mentioned, or cases similar to that. For this kind of, in general, children and adolescents especially, taking them away from their familiar environment, put them in the hospital. That would be an addition to their kind of devastating thing. They don't know where is this place, what is this and that. Is there any home health service available, for example, for an skilled nurse to give them medication at their home to take care of them? Maybe even that is less expensive than putting them in the hospital, even for the expense issue. So I was wondering about that.
Yeah, thank you for that comment, Dr. Rabbani. That's an excellent question. Here are the so yes, they are actually available. I don't specifically know if the waivers approve for the caregivers to give them medications, but I know there are a lot of services where either they stay at an FHP's home, or there will be a caregiver there during the day to help them with day-to-day tasks. I don't know specifically whether they give them medications, but I imagine they will. And I know in Michelle P. waiver, PT and OT services are also provided. I don't know if that's to their house or just at the PT office. But yeah, actually, these waiver services, they provide a lot of services for the patients.
Okay, thank you.
Dr. Casey?
Just to comment on that a little bit, that's part of the attendant care that goes along with these waivers. So yes, you can hire a caregiver to come into the home who can, if it's part of their regimen, administer medications. They can't do as needed medicines in the same way as a parent or other caregiver would, but they can administer some medications. But almost universally, people have trouble getting people to take those shifts. So staffing has been a major issue for the families that have tried to get attendant care. And the more dysregulated the individual, the less likely they are to actually find somebody. It's not like there's an agency for the signs. You have to go out on your own and find somebody, and it's catered based on resources.
Thank you for that comment. I did not know that. Thank you.
And Will, this is Arthur. I thought it was you did a really good presentation. I did want to comment a little bit on the ECT aspect, going off what Nick was saying. So when I was at the APA this last year, they actually had a really good presentation on ECT for severe autism, especially for stereotypic behaviors. It was a new study, so I'm not sure if they've even published yet, but they were giving some preliminary data. It's coming out of the Northeast, and their data was showing that for repetitive behavior and agitated behavior, their study showed really good results. So I do think, going off Nick's question, neuromodulation, especially the ECT for these repetitive, almost catatonic-like behaviors, and whether it is true catatonia or just agitation, it does seem to be very effective, just from like the few studies I've seen. And I'm glad you include that in this presentation.
Thank you. I got to keep an eye for that paper then. Oh, hey, Dr. Bauer.
Great presentation. I have two questions. The one is, when we have patients admitted to free norms who have intellectual disability, a lot of them have behavioral issues, and some of them want to kill themselves every day. Do you have any studies that deal with what behavioral methods can be used on an inpatient unit for a patient who has ID and repetitive suicidal ideation or cutting? If anything is effective in terms of that. And then the second question is, the example that you gave in the beginning, that the patient has biting and then biting on and then hitting grandma.
Right.
So a lot of them have the behavioral issues, and they have these issues already, like biting and hitting. So should that be a consideration that this is a new behavior, like Dr. Swanson mentioned, that this lady was having auditory hallucinations and putting things in her vagina, which is not like, a normal ID behavior, but biting and hitting are normal behavior. So should it be a medication adjustment at the level of EPS and sending the patient, or should it be an admission for every such case coming to the EPS?
Those are two wonderful questions. Thank you. I think for the first question, I think it'd be helpful for us to know the, I guess, behavior techniques a little bit. for, self-injurious behavior because, as I listed in the examples, social reinforcement has a role, and the ABA behavioral techniques basically use positive reinforcement. So I think if you are familiar with those, types of techniques as a physician, perhaps you could look at what is the antecedent, what is, what kind of consequence do you want to get out of them? Do you want to, try to use positive reinforcement much as possible, and things like that. I think being familiar with those techniques is helpful. And I personally, I've just read superficially about these things, and I haven't read a book about it, but I imagine there are books. And for the second question, I think if the person's self-injury gets a lot worse than their baseline and the family is feeling like they can't be safe and they're getting out of control, they've exhausted all the community options. And I think, if the family seems motivated to get them better and keep them in the community after discharge, I think you admit them if you have to. That's just my thought of it. Dr. Casey?
I think a lot of that has to do with how much support do they have at home, and what can the family reasonably provide, and what they cannot provide. And if it's a safety issue, well, that's when you have to bring them to the hospital. You might be willing to tolerate a certain amount of it, but if there's a major change, or to a physical issue that's manifesting as a behavior problem, or a person with different psychiatric condition, or if their care needs are just higher than what can feasibly be provided at home safely.
Very well said. Thank you.
Yeah, and also, to answer your first question, usually when you have a waiver, you have a behavioral therapist at all these facilities, and that's part of the treatment plan. However, when you come to a community hospital, most of the staff are not trained to work with this population, especially with these techniques. So that's often the argument not to sometimes admit these patients because, how do you appropriately go about treating these patients in this kind of setting? Like in Chicago, where I worked, there were several hospitals where specifically just for patients with intellectual disability. Of course, you can never get them in there; they're always full. But that's that. Those staff are trained with this population to work with their aggression, agitation, the hitting, biting. So it's a different approach. So you can argue both ways, but generally most community hospitals, that's that. Most of the staff is not trained.
And to add on to that, I think that hospitalization can sometimes worsen a person with intellectual disability, that the change in routine, the lack of access to normal outlets, the lack of familiarity, the potentially other scary people on the unit or things that they can't understand. I've had lots of patients who were traumatized by being in the hospital. Not that there was a good alternative, and that's why we hospitalized them. But in retrospect, I have wondered, did I help this person, or did I, in some cases at least, make it worse?
Thank you.
And just to piggyback off on another question that Dr. Ladama asked about Dr. Oliva, ECT was, you mentioned in your slide, it's used for psychosis, self-mutilation, and stereotypies. So, like, I think out of University of Cincinnati, they do a lot of ECT with patients who do not respond to traditional therapies for self-mutilation. And ECT has been shown to be very effective. Catatonia has a high prevalence actually in intellectual disability, and it's been shown very well. I'm not familiar with the study that the APA that Dr. Olio was referring to, but something to look forward to. But we haven't done so much of that here at U of L, but I know University of Cincinnati, based on from what I read, they do a lot of that work up there.
Let's see here. Dr. Ive raised his hand.
Hey there. Hey, great talk. I really appreciate it. So this, but a very common presentation in EPS is a patient with mild intellectual disability who is currently staying at an FHP or a group home. They run away, or they act out behaviorally, and the reason for that is because they don't want to live there anymore. They don't like the FHP. They don't like where they're staying. They get brought to EPS because of these behavioral issues. They explain it very well, the reason why they are having these behavioral issues. So it's not really something psychiatric that you can treat with medication. And then we end up discharging them back to the FHP. And oftentimes you have guardians who they've already talked to multiple times about how they don't like living there. They want to live more independently. They want to get a job. They want to start relationships. They want to be, on their own. And I look at a lot of these patients, and they're a lot less impaired than oftentimes chronic schizophrenic patients that we discharge from EPS, straight to the street. And so my question to you is if you know of any actual like legal avenue or any thing that the patient can do after they're outside the hospital in order to try to gain some independence like that.
Yeah, that's a wonderful question, Doctor. I wonder if they could go to the court and try to petition for them to be their own guardian. But I think although the Commonwealth of Kentucky's Council for Disabilities says on their website supported decision making is recommended, I have not yet had a patient who has that form of decision making sort of structure. So I do not really know practically how one can do it, but I agree with you. And that's what I wonder is lots of patients who seem intellectually, just borderline or live in FHP. They want independence, and so, Dr. Casey.
There's not a good answer to some of that. They are able to contest their guardianship, but someone who has intellectual disability is going to have a pretty hard time navigating the system or paying to have that process done. As far as what I do with them in the outpatient sort of encounters, I talk about, working towards independence is a great goal, and I try to encourage them to work on independence within their current setting and demonstrate they need less help. And as they do so, people might be able to back up and have realistic, more real elements of their life they have control over. But they only had intermittent success with them.
Yeah, and I mean, even if there was if they petition for it to be their own guardian, or whatever, even just to have access to either go to the courthouse or to talk to somebody in order to petition for that themselves. They have very limited access depending on the FHP's involvement in that. So I don't know, I just feel like maybe some of our financial structure in this country is aimed towards things that maybe would be better used elsewhere.
Yeah, thank you, Dr. Ive. I see Dr. Swanson raise his hand again. No.
Yeah, can you hear me? Yeah. This is a great conversation, and it really highlights a lot of the complexities and challenges. It just so happens that as we speak, there is a real-time situation occurring right now. There's a patient of ours next door at Bingham Gardens who has a history of schizophrenia, and he has moderate intellectual disability, and he acts out at times. And I have seen him when he's decompensated and psychotic, and probably the most striking example of that occurred a couple of years ago when he threw a bowl of hot soup into a nurse's face, accusing her of putting semen in it, and he was paranoid. And at that time, he responded to an increase in Haldol. And but over the past 6 weeks, he's been refusing meds. He's lost 20 pounds in the past month. He's refusing to eat. He's refusing to bathe. He's refusing blood draws. In the ICF, of course, there are, as is the case with inpatient and other places, there are rules against restraint and this sort of thing, but the patient is clearly decompensated. And we have been on the phone with PES. He said he spent the night in PES, and he is being admitted today, but we just can't stabilize him. He is in an ICF. He's with excellent staff, excellent nurses who know him. We are just across the street. We are walking over daily and looking on him. We can't get him to take meds. His situation is complicated by he's got a low white count, and we'd like to get him on clozapine, but we can't get him to follow up with blood draws. And his white count is low, and there's some hesitance for long-acting injectables. But he's kind of the classic schizophrenia patient who is decompensated, and we just can't stabilize him in the community. And I guess he's being admitted to 3 North today. But again, for all the reasons cited, there's hesitancy in doing that, but we just can't get him well as an outpatient. So we're grateful. We're hoping to get him stabilized on inpatient and get him back as quickly as possible. Thanks.
Thank you. Oh, Dr. Pacey.
I have one more comment, for changing the topic a little bit, but disability advocates have mixed feelings about the supported employment model that we have currently. So the sub-minimum wages is the big thing that they disagree with. I think their argument is you are saying by paying someone less, you are suggesting that their labor matters less. And they are really against that.
Yeah.
So, but then employers are saying, well, we wouldn't. If we had to pay more, we would just pay someone who wasn't disabled to do more work. Kind of, that's a topic that's been in the news within the last year or so.
Yeah, I bet it is. I personally don't see why not. Because we look at the income statement and it results in more value for the society and more value for the people. I personally don't see why not. Just keeping them employed, albeit lower wage. Did Dr. Shah want to say something?
Yeah, hey, Will, thank you so much for such an excellent presentation and generated so much discussion. I actually had a question regarding the ABA therapy. More recently, I've read more articles there's a lot of controversy regarding ABA, that it's more harmful than helpful. Do you have any insight into this?
Yeah, I read that. I read about that a little bit, and it was saying that I forgot what it was saying, but I remember reading something about the controversy. Did you recall what it says? The specific harm was?
Oh, sorry. From what I recall, they said that it's more, making them be more not making, trying to make them separate versus being in like normal people, like neurodivergent. And there's just like a lot of debate regarding that. So I just wanted to know if you had anything, especially the punishment aspect that we're saying that's really harmful for that patient population.
Yeah, I know. I mean, I can sort of see the problem, it's completely breaking down behavior into like individual components and rewarding it, positive reinforcing the good behavior. And have you read anything about alternative behavioral methods?
Honestly, not really. But I was just wondering if you had any idea.
Yeah, no, I think my research was I pretty much look at the ABA, and at the specialty clinic, I feel like the behavioral therapist there was probably registered behavioral analyst, so I presume that's ABA. So yeah, I actually don't have any exposure to any alternatives, but I'm open to reading about the alternatives.
Awesome, thank you.
Thank you, Bhumika. Any other questions? Okay, well, everybody, thank you for your attention today. Hope you have a good rest of your afternoon.